Thank you very much. Can you hear me okay? Good. So what I'm going to present now is going to be a collaborative effort. That's not my work. That's the work of few people that I will mention. Some of them are really actually sitting here in the audience. Looking at best practice guidelines for the diagnosis and the management of acute kidney injury. So we know that acute kidney injury is a relatively common disorder. We also know that it is associated with high morbidity and mortality. But the body of evidence regarding the diagnosis and the management of acute kidney injury is really lacking in veterinary medicine. Now, the main thing that had occurred over the last probably decade or so, or more than that, was the introduction of renal replacement therapies. So this is an advancement in the treatment, yet the overall mortality rate in dogs and cats with acute kidney injury is relatively high and remains high. If we look at few studies and the mortality rate of in animals with acute kidney injury, actually we don't find a lot of studies looking at cats. We see multiple publications regarding cats with urethral obstruction, but we don't see a lot of publications and studies looking at acute intrinsic kidney injury. You can see that the survival rate is not very high. If we look at retrospective, big, large-scale retrospective studies in dogs, we had to rely on a very relatively old study from 1997, looking at 99 dogs with acute kidney injury. You can see the high mortality rate here. Recently, we had published a study looking at around 250 dogs with acute kidney injury to show that the mortality rate is actually a bit lower, but still relatively high. So to that end, the IRIS had constructing a working group to provide some guidance for the diagnosis and the management of acute kidney injury. These are the members of the working group. So we have the team from Switzerland, Terry and Arian, which are also here. We have Roseanne from the Royal Veterinary College. We have J.D. Foster, Kathy Langston, and we also have two critical lists that were incorporated into the groups to provide some insight from the critical list point of view as well. So these are the working group, and the way it worked is that we had multiple online meetings, dozens, probably hundreds of hours. Yeah, the Switzerland team is laughing because this was a very long process. Online meetings to actually generate statements regarding the diagnosis and the management of acute kidney injury. Once we had completed that process, we had sent that for a formal consensus voting. The people who voted on these statements were the IRIS group members that were not part of this working group. And they had to say whether they are to vote on the level of agreement for each one of these statements, from strongly agree to strongly disagree. And only those statements that had received at least 75% of the voting saying that they are strongly agree or agree were accepted. If we didn't reach the 75%, we had to revisit the statement based on the comment, and overall we generated more than 50 statements. I'm not going to present them all due to time limitations, so just selected few of them. And the way it's going to work is the way, and all of these is going to be available hopefully soon as a publication. And the publication would look like this presentation. Every time you see this box with these undefined colors, that means that this is a direct quote from a statement. And everything around that's going to be a rationale, explanatory text, and this is the way it's going to be in the manuscript, hopefully. So we have statements and we have some rationale before and after the statements. So first we just did a little bit touch on the definition, and this is kind of trivial, but acute kidney injury is an injury to the renal parenchyma, and the emphasis here is that can be with or without any change in kidney function. So we think about acute kidney injury as accumulation of uremic toxins, but oftentimes we have an injury that is unassociated with a change in kidney function, and we have to recognize that. And actually this is the best probably period of time to identify these patients and prevent these patients from deteriorating later. There are multiple causes for acute kidney injury, and therefore it is highly recommended to do a diagnostic workup to look for the underlying cause. The underlying cause will give us a lot of information regarding the prognosis, the treatment that we need to provide for these patients. So you have to do a diagnostic workup to identify the etiology. It is true that in some of these cases we cannot identify the etiology, but we still have to do that. Now, what would be a reasonable test depending on the etiologies? If we look at the literature, the last retrospective study that we had done, that was the distribution of etiologies in our institution. Does not necessarily mean that this is the distribution of etiologies in your institution. Probably not, or not necessarily. And we also have to recognize that there is a shift in etiologies over time. So these two studies are just an example of how these etiologies shift over time. The first study is a study that we had done to generate a scoring system for acute kidney injury for those animals who are managed with hemodialysis. This is assessing the severity of the disease objectively and try to provide some prognostic information. And we followed this study 8 years later with additional study looking at a different cohort of patients and to validate the scoring system. And what we had seen that over 8 years, which is a relatively short period of time, etiologies had shifted within the institution. The same institution had different distribution over 8 years. Leptospirosis, ethylene glycol intoxication, these kind of etiologies. So it's really important to know what are the etiologies in your region, and this is a moving target. Acute kidney injury can be hospital-acquired or community-acquired. And I think that as a profession, we mostly looked at acute kidney injury as community-acquired. In community-acquired acute kidney injury, the acute kidney injury insult happens outside of the hospital, and usually there is a few days delay between the onset and presentation. And sometimes they may present due to completely different clinical signs. They are not presented due to azotemia, but rather due to concurrent symptoms or diseases, and we identify acute kidney injury. We have to also recognize that some of these acute kidney injury never been recognized. There's acute kidney injury, maybe mild increase in creatinine concentration after anesthesia, going down, healing process, and we never recognize that. But what seems to be the case in recent years is that hospital-acquired acute kidney injury is becoming more prevalent. And this is something that we had seen in our study as well. And this is the case actually in the human field, in human medicine, most of acute kidney injuries happen in the hospital. And the reason why we see that in our veterinary patients probably relate to the fact that we manage nowadays patients more intensively. We have more geriatric patients. We have patients on ventilator or invasive procedures. Some of these patients are hospitalized for a long period of time. Some of them have multiple comorbidities, and so they have hospital-acquired acute kidney injury. So in our study, more than 20% of animals with acute kidney injury actually had in-hospital acute kidney injury. We have to recognize that as a profession, probably in the hospital setting, this is becoming more and more common. Obviously, the diagnosis is based on the history, physical examination, and laboratory tests that indicate that we have an injury or change in kidney function that occurred over a relatively short period of time, less than 48 hours. That would be a definition of acute kidney injury. It may be tubular, it may be glomerular. And the diagnosis, it's much easier when we have baseline function known to us. So if we have like serum creatinine concentration at presentation, because these animals are presented and we do diagnostic workup, then the diagnosis is much easier. Because what you do now is basically compare the subsequent creatinine measurement or SDA measurement or whatever marker that you are using to previous measurement. And here we are in line with the IRIS recommendations. In those patients, if you have an increase as small as 0.3 milligram per deciliter in those hospitalized patients, that is enough to define acute kidney injury. So in those animals that we have baseline creatinine concentration, we know what the baseline is. We don't care about reference range anymore. We just compare subsequent creatinine to the baseline, and that will increase our sensitivity. What do we do with the community-acquired acute kidney injury? So in those animals, we have to assess, based on all the information that we have, whether the serum creatinine concentration that we are now looking at is higher than the presumed creatinine concentration of this animal when it's on steady state. Now, sometimes it's really easy, right? If you have an animal presented with a acute onset of clinical signs and creatinine concentration is like 12 or 15, you know that that was not the baseline, right? That is an acute insult. But what do you do if you have a dog that is presenting with non-specific clinical signs like vomiting, diarrhea, and creatinine concentration is 1.8? Is that the baseline? So we're looking at the history of physical examination, ultrasonographic findings to identify and to make an assessment whether this is actually representing an acute insult or not. But regardless if we can make this very confidently or not, we can follow these animals, and usually if it's acute kidney injury, this is a very dynamic disease, so creatinine would change and probably will fulfill the criteria of hospital-acquired AKI as well. And so we can, even if we cannot make this assessment immediately, we probably will be able to do that in subsequent days. So once we identify the acute kidney injury, what would be the diagnostic workup that we recommend? We do recommend performing urinalysis. We also recommend performing urine culture. We know that these patients may not necessarily present clinical signs that are typical of lower urinary tract infection, to know that these animals are at risk for infection or pyelonephritis. So we do recommend culturing the urine. We do recognize, based on the information that we had from the last retrospective study, that pyelonephritis is not very common diagnosis of acute kidney injury in otherwise healthy dogs. We don't have that information in cats, but was not very common. But yet, if we look at two studies evaluating acute on chronic kidney disease, which is also acute kidney injury, the baseline is different, but this is the acute insult. Pyelonephritis was a presumed etiology in high proportion of these cases. So we do recommend culturing the urine. We also recommend performing ultrasound examination to look for the etiology, to identify comorbidities, and to assess whether we have chronic changes in the kidney. And blood pressure is also a diagnostic workup that we have to perform, and we'll talk about that a little bit later. Now, one of the questions and discussions that we had is, what do you do when you diagnose grade 1 AKI? Now, in reality, we don't identify these patients very early in the course of the disease, and most of the patients are presented in higher grades of AKI. But probably with the introduction of new biomarkers, which are going to be more sensitive, we would identify grade 1 AKI more commonly. So what you see here is a marker. This is clustering. It can be cystatin B, it can be other markers as well. And you can see that it's very high in animals with acute kidney injury. But it's also high in animals with acute kidney injury grade 1. And when we screen some animals that are considered to be at risk, in some of these animals, this marker is also high. So these animals should be diagnosed with grade 1 AKI. So if you do that, let's say that you have a marker like that, and hopefully it's going to be available for us soon, and you have measuring that post-anesthesia, for example, and you identify an increase in that biomarker, what do you have to do? Do you need to hospitalize the patient due to grade 1 AKI? So the decision that the consensus that we had made was that these patients do not necessarily need to be hospitalized if you have only grade 1 AKI. However, you need to address them like an AKI patient. That means that you need to do a diagnostic workup to identify the cause, if you don't know what the cause is. You have to discontinue any nephrotoxic medications, and you have to monitor these patients very closely, initially daily. Because we know that the transition between one AKI grade to the other may be as short as few hours, and the transition from grade 1 AKI to grade 5 AKI may be as short as few days. And we also know that the prognosis of those animals with higher grade is decreasing over time, so the time to intervene would be in the early stages or grades of the disease, and I will show you some evidence for that as well. So it's really important to really monitor these patients, even if we make the decision not to hospitalize them. We have a lot of information in the manuscript regarding fluids, and I don't think that we have to spend a lot of time on that due to our time timeline. Just to mention that with fluid administration, the first goal is to restore tissue perfusion. If we have hypovolemia, that should be corrected almost immediately within 1 or 2, no more than 2 hours. We do that by administration of crystalloids at boluses for dogs and for cats, and we have some recommendations here. Dehydration should be corrected relatively rapidly as well, within 6 hours, unless we have contraindication for rapid fluid administration, which is mostly cardiac diseases. And if you do, you have to do it slower. So the first goal is to restore perfusion. That has to be done immediately, and then dehydration has to be corrected over a few hours. Overhydration must be avoided. This is something that we emphasize over and over again over the years. Does it help us a lot to re-emphasize that? I'm not sure, because many of the patients that we see with acute kidney injury still are presented with overhydration. So this is something that we will continue saying probably, but maybe we are improving slowly. Few words about type of fluids. We recommend avoiding saline, sodium chloride, just because these fluid types has excess of chloride. And it has been shown in human patients that excess of chloride is associated with persistent acidosis. So it's not really the pH of the solution by itself, it is the excess of chloride, and so we recommend not using saline. What about colloids? We had a lot of discussion regarding colloids. What should we do with that? And we cannot ignore the evidence coming from the human side suggesting association between acute kidney injury and colloid administration. If we think about what is the evidence in veterinary literature, it's actually all over the place. There are some studies looking at healthy dogs and whether these animals develop acute kidney injury after colloid administration. Some of them are looking at very sensitive markers and cannot find any evidence for that. Some of them suggest that there may be evidence for that. There are some retrospective studies actually finding an association between colloid administration and AKI. So this is concerning. However, we need to bear in mind that in those retrospective studies, if you think about that, who are those patients that receive colloids? Probably these are the most severe patients. These are patients with severe hypoalbuminemia or patients with unresponsive to fluid resuscitation, and probably the risk of AKI in those patients is already higher regardless of colloid administration. So that is a little bit something that we have to consider. There are some other retrospective studies that did not identify these associations. So what do we do with colloids? And so finally, and that was going back and forth over and over again, we did, and this is coming mostly from the ICU people, suggesting that due to the controversies regarding the superiority of colloids over crystalloids in resuscitation and potential nephrotoxicity, colloids should be avoided in the AKI patients. So that's what our recommendation. We had the debate, what do you do with animals on hemodialysis, because sometimes these animals have hypovolemia and are unresponsive to fluid resuscitation, but that is a different scenario. So generally speaking, we recommend avoiding the use of colloids in AKI. What about diuretics? That was an interesting discussion as well. How many of you guys are using diuretics in the management of acute kidney injury? Only a few. I can ask the different way. How many of you do not use diuretics? Okay, so I can assume that the others probably are using diuretics. So that is a debate, okay? So here is the kind of the discussions that we had. We know that decreased urine production is the common feature of acute kidney injury. We know that the utility of diuretics in preventing and management of AKI has not really been evaluated very thoroughly in veterinary medicine. And this is an overstatement. Basically, we don't have studies. So currently, if you want to think about that way, if you are not using diuretics and you're looking for support, there is no evidence to support the use of diuretics. Okay, that is the one way to look at that. But we also know that anuria and oliguria are relatively consistent risk factors for mortality. Is that because of anuria, or that is just a representation of the severity of the disease? We have to make a decision about that. But we also recognize that attempting and converting anuric patients using diuretics may be beneficial for helping us to manage the disease, not necessarily to facilitate recovery. But if you have the ability to convert anuria, and now you have urine production, you probably, if you have a patient that is overhydrated, now you can get rid of these fluids. If you have we know that overhydration is associated with hypertension, so it's easier to control hypertension. We know some of these diuretics, we'll talk about that, increase the fractional excretion of potassium, so you can manage hyperkalemia in those patients. So there are some beneficial and theoretical effects for diuretics. We do recognize and emphasize that diuretics should not be used until dehydration had been corrected, but then do we use them or not? So let's look at specific diuretics. Let's start with mannitol. What is the evidence for mannitol in acute kidney injury? Basically, none. You can see two studies here. One was published in 1996. The other one is more recent. But those two studies looking at the effect of mannitol on the healthy kidney. So does mannitol have an effect on the healthy kidney? The answer is yes. Does it increase GFR? The answer is no. It may increase GFR only mildly after bolus administration, but this effect is very short-lived and you cannot maintain the effect with concentrate infusion. So if you are giving mannitol to increase GFR, that's not the case. Based on the evidence that we have on healthy animals, it does not do that. It does increase the fractional excretion of urea and sodium, and there is some theories that this is a free radical scavenger, so it may have additional potential beneficial effect in the management of acute kidney injury. What we do not recommend doing, or actually recommend avoiding, is giving these animals repeated boluses of mannitol if they are anuric and not responsive to your first bolus, because that's going to promote overhydration, hypervolemia, hypertension, and severe electrolyte disorders. So you can do it once. If you have a response, you can continue with CRI if you are a believer. But if not, don't repeat the mannitol boluses over and over again, because that's going to make more damage. What about loop diuretics? In theory, they have some beneficial effects. They will reduce oxygen consumption, which is an issue in the kidney. In human patients, so if we look at the evidence coming from the human side, basically loop diuretics had failed to prevent AKI in those human patients that are at risk for AKI, and they did not change the outcome of these patients. So if we're looking for the evidence coming from the human side, diuretics or loop diuretics do not make the difference. So it's really important to have realistic expectations from the use of diuretics. Yes, they may help us to manage the disease, but they are not likely to improve renal recovery. And they should not delay dialysis. If this dog with acute kidney injury fulfills the criteria for renal replacement therapies, do not delay dialysis because you had not tried the use of furosemide, okay? You can use furosemide and it would have potential beneficial effect in promoting urine production, managing overhydration, hypertension, hyperkalemia. In theory, increased intratubular flow may facilitate the removal of luminal debris and further obstruction, but again, this is only in theory. We know how many drugs in theory work and in reality do not. So what about dopamine agonists? We know that dopamine agonists were kind of on and off over the years. If we look at dopamine initially, so we have dopamine and phenoldiazepam. So in dopamine initially, again, we don't have a lot of studies. However, if we look at the human literature, basically there are multiple studies, including meta-analysis, that do not find any beneficial effects of dopamine. And so due to the potential side effects that results from activation of alpha and beta adrenergic receptors, we do not recommend using dopamine in the management of acute kidney injury. Again, in theory, you may argue that the low dose of dopamine for renal, the renal dose should not activate alpha and beta adrenergic receptors, but we do not know that this is actually the case, and that may worsen hypertension. So based on the evidence, a lot of evidence coming from the human side and potential side effect, we do not recommend the use of dopamine. What about phenoldiprem? Phenoldiprem doesn't have these side effects of alpha and beta adrenergic activation. So we look at the studies out there, and there is one study looking at the effect of phenoldiprem on the healthy kidney, again showing that it does have an effect. But if we look at studies in animals with acute kidney injury, this is a retrospective study with all the inherent limitations of a retrospective study, looking at 30 dogs, around 30 dogs and 30 cats. And in this study, they could not demonstrate any beneficial effect of phenoldiprem. This is a study that we had performed a while ago, looking at animals in heat stroke. And basically all the animals with heat stroke have some degree of acute kidney injury. Sometimes it's grade 1, but they all have acute kidney injury. So this is a prospective double-blinded placebo-controlled clinical trial when we try to give phenoldiprem to one group to see if it would prevent acute kidney injury, or would it change the outcome of those patients who develop acute kidney injury. We looked at multiple parameters, including GFR and fractional excretion of electrolytes, and basically we did not find any effect. And so based on these evidence, which are not very strong, and due to the cost of the medications, phenoldiprem cannot be recommended at this point as part of the management of acute kidney injury. Few additional areas, and again, I'm skipping some of the statements that we have. Phosphorus, we don't have to talk a lot about phosphorus, and probably I don't have to emphasize that to this group, but we all see that coming from referring veterinarians about the use of phosphorus binders in the acute kidney injury settings. So we know that phosphorus is accumulated and retained in acute kidney injury. We know that it is associated with the severity of the disease, and it has been identified as a risk factor for mortality in some studies. But it was important for us to emphasize that phosphorus binders should be avoided in patients that are not eating voluntarily a phosphorus-restricted diet. So if you are just pushing phosphorus binders to these patients, like aluminum hydroxide, basically you are supplementing aluminum to these patients, because these binders do not bind the phosphorus in the body. They are mostly bind the phosphorus in the food. So if they are not eating, don't supplement aluminum. That's probably not a good thing to do. And so we do that because all of us are seeing that, and it was important for us to identify that. Calcium, we also had some debates about calcium, because what do you do with calcium? Most of these, some etiologies of AKI may have hypercalcemia, but for the most part, these animals have hypocalcemia. And hypocalcemia is multifactorial, probably is resulting also from accumulation of phosphorus and binding of phosphorus with calcium and promoting mineralization as well. So if you have patients with hypocalcemia and you just give calcium, probably you are promoting more and more mineralization. But sometimes this hypocalcemia may be severe. So what do you do with these patients? So finally, we had made the decision that you treat hypocalcemia if hypocalcemia is severe, and we had defined severe using this number, 0.75 ionized calcium, or you have clinical signs. And when you do that, do not try to correct hypocalcemia. Try to avoid or to address the clinical signs, or be higher than this value, which we had defined as a very low value that we don't want to be below it. So that is our recommendation. Do not try to normalize calcium concentration. Just eliminate clinical signs and avoid severe hypocalcemia. Gastrointestinal signs, we all know that these gastrointestinal signs are present and common and are in association with the severity of the disease. We all use medications to prevent these clinical signs and obviously to make the patient more comfortable with the disease. However, on top of that, it's really important to prevent esophagitis, negate the already catabolic state, and decrease fluid and electrolyte disorder. So it's not only making the patient more comfortable, we do recommend a multimodal approach, an individualized approach using different medications, working on different mechanisms to avoid these effects of gastrointestinal signs. Nutrition, and now we have nutritionists here in the audience. So let's talk about nutrition a little bit. So first, we have to recognize that these animals with acute kidney injury, when the acute kidney injury is severe, they are really catabolic. And this is a study that was started and initiated by Thierry Francais. When he was in Davis, I had the opportunity to complete this study, looking at nitrogen balance of dogs with acute kidney injury. So basically what you see here is nitrogen going in and going out, and nitrogen going in. And so these patients were all managed by hemodialysis, so we had to we did a partial dialysate collection to measure nitrogen in dialysate. We had urinary catheter in place in all of these patients, so we know how much nitrogen is being lost. All of these patients had feeding tubes as well, so we knew how much nitrogen is going in. If you do the balance, you can see that these animals have very high negative nitrogen balance. If you only convert this nitrogen into calories, this is almost 20% of RER. And so even if we intervene early, and these patients had early intervention with nutrition, still these patients are very catabolic. So our recommendation was to use 1.3 times RER during initial phases of acute kidney injury to try and negate the weight loss. And despite this relatively aggressive management, that means placement of feeding tubes very early in the course of the disease, these patients had lost around 1% of body weight per day. So in severe acute kidney injury, these animals are really catabolic. So we do recommend early and proactive intervention. It should be individualized, and you can use whatever way that you are comfortable with. Esophageal feeding tube, PEG tubes. You can use the post-pyloric feeding technique in some of these cases if that is indicated. But whenever anorexia persists or expected to persist more than 48 hours, nutritional support is indicated. Now, what do we feed them? So let's start. So before what we feed them, so we highly recommend to use the enteral route if possible, and feeding tubes are preferred. And oftentimes we hear that these animals in which feeding tubes cannot be placed because they have acute kidney injury and anesthesia cannot be performed. So it was important for us to actually state that general anesthesia can be provided safely in most patients with acute kidney injury. We do it almost routinely in these animals. We place feeding tubes all the time in these animals. If anesthesia, for whatever reason, is contraindicated, then you can use nasogastric or nasopharyngeal tube or parenteral nutrition. But we highly recommend using feeding tubes in these highly catabolic patients, early intervention, individualized intervention. What should we feed them? So we basically wanted to say what we do not recommend feeding them, and these are renal diets. We do not recommend initiating nutrition with renal diets. These renal diets have protein restriction. You saw the nitrogen balance of these severely catabolic animals. They do not need to prevent protein. And the second issue is that some of these diets that have protein restriction are relatively high in fat. And at least in dogs, we want to avoid that because we are aware of pancreatitis being a relatively common complication in animals with AKI. So when we looked at our study, which included dogs in all AKI grade, we identified around 20% of animals with AKI that had concurrently pancreatitis. In a study coming from Davis, and these are more severe cases because they are all undergoing intermittent hemodialysis, they had identified 60% of the cases. So regardless of the exact proportion, these are relatively high proportions, so we try to avoid using high-fat diet. Hypertension is a relatively common complication in these patients. We recognize based on the literature that up to 80% of the dogs and 60% of the cats will be hypertensive. We also want to emphasize once again that iatrogenic fluid overload is a contributor to hypertension. And the most common manifestations that we see in hypertension include, in the AKI setting, seizures and retinal detachment or ocular manifestations, which I think both are life-threatening. You may argue that neurological manifestations are life-threatening, but ocular manifestations are not. I think in the AKI setting, severe AKI setting, when euthanasia is always on the table and an option for many of these owners, additional complications like that are actually life-threatening for the patient, because owners may just elect for euthanasia because this is another complication. So we do recommend monitoring very frequently, at least 2 times a day, probably more than that, and be aggressive with the management. We don't want these patients to be higher than 160. We heard about coagulation disorders and decreased platelet function, and so these patients have higher risk for bleeding. The medications that we are recommending are amlodipine and hydralazine. We do not recommend the use of ACE inhibitors or ARBs during the AKI setting. Few words about hospitalization and recovery. Hospitalization time often is not dictated only by the improvement of kidney function, but also due to concurrent complications and comorbidities. The inciting cause is very important determinant of the prognosis. We know that some etiologies tends to be reversible and others do not. So inciting cause, identifying the inciting cause will also help you in prognostic projections. A lack of improvement in kidney function parameters within the first day does not indicate the inability to recover. And the reason why we have that here is because we often get these phone calls from referring veterinarians saying, I'm hospitalizing these patients with acute kidney injury now for 3 days on fluids, creatinine is not dropping, is there a chance that this would happen? And the answer is absolutely yes. Actually, it's not very common for these patients to recover in 1 or 2 days. This is not hemodynamic change, this is not post-renal azotemia. The kidney actually has to recover. That takes time. And if you look at the median hospitalization time of patients that recovered from hemodialysis, that was approximately 1 week. So it takes a lot of time. Some of these animals, it takes weeks and weeks until they recover. Not all the process has to be in the hospital. Sometimes they will continue to recover after discharge as well, and I will show you some data on that. But that's really important was important for us to emphasize. These patients do not recover in 1 or 2 or 3 days. What about the association between severity and mortality? And so that was another point of emphasis, because sometimes people believe that if the dog has a very high creatinine concentration, it is not likely to recover. And so we want to differentiate between reversibility and severity. These are 2 different things. You do see the association between the severity and recovery, and I think that severity oftentimes dictate the window of opportunity for recovery in the absence of dialysis. If you have a dog with a creatinine concentration of 15 or 12, probably this dog, even maybe he can recover after 1 week, but he doesn't have 1 week. So organs are going to be affected. These animals may die from multiple organ dysfunction before they have the opportunity to recover. If you have dialysis, these grades are less important. So we see this association, but don't make the judgment that if the injury is very severe, it's not likely to recover. And actually, many of these animals do recover. And I think if we look at the recovery rate, we have much better results compared to what we previously had. Because if you think about that, based on the previous studies, the Vaden study from 1997, basically we had 57% mortality rate. So we used to tell owners 50% of the dogs will die, 50% of them will survive. Now, of those patients that would survive, the information that was available is that 50% of those will have normalization of serum creatinine concentration and 50% will not. That means that they will develop CKD. And we know that CKD is a progressive disease in dogs. So if you take that collectively, basically you tell the owners 75% of the patients with AKI will either die or will have chronic kidney disease, and they are expected to deteriorate over time. That sounds really bad, right? That was the reality. Our results are a little bit different. So first, in our study, survival rate was 66% and not 43%, so that is the big difference. Of those patients that survived, again, consistent with the Vaden study, 50% of those patients had complete normalization of serum creatinine concentration. But as opposed to the Vaden study, we had followed these animals for a long period of time. An additional 20% of those patients had normalization of serum creatinine concentration during the follow-up period. So basically 75% of these patients have complete normalization of serum creatinine concentration, and the overall survival is much, much better. It's true that some of these patients will develop chronic kidney disease. But again, here we also have additional good news today, that those animals with chronic kidney disease actually do not deteriorate that fast compared to what we had expected. And we talk about why is that maybe in the next lecture, but these animals seems to be very stable over time due to multiple reasons that we are going to mention. But you don't see a difference in survival rate between those animals that had complete normalization of their serum creatinine and those patients that did not. So I think this is really encouraging for owners that want to manage animals with acute kidney injury. So I think I'm 3 or 4 or 5 minutes over the time. I'll try to compensate in the next lecture. I want to thank again the working group for spending so many hours during the evenings generating these statements. Again, these are kind of probably half of the statements that we have. This is all going to be available hopefully soon in the veterinary journal. So you have a very extensive document that you can look at all the details. So I'm going to stop here. Do we want to do questions now, or do we want to move to the next one?
Sure. I think that would be great if we could pause for questions. So thank you, Gilad, for a very informative update on the consensus guidelines. Wonderful. So if you have a question, please raise your hand. We'll get a microphone to you. And while we're getting the microphone to you, I'm happy to start with the first question. So you touched on the increased prevalence of hospital-acquired AKI. And we know from the human side, there's also an associated interest in the predictive algorithms for identifying which patients are at highest risk. So on the human side, a lot of these are focused on cardiovascular risk factors, but presumably would be different in canines, felines. So from your clinical experience, what are the factors that you look for?
Well, so I think we have some differences from human patients to our patients, and certainly cardiopulmonary bypass surgeries are associated with acute kidney injury. We don't have that prevalence in veterinary medicine. I think that the combination of decreased tissue perfusion and inflammation is very important. Those animals in sepsis and decreased perfusion probably would be at a high risk. So I would look at these patients, obviously animals presented with congestive heart failure that receive diuretics and maybe sometimes aggressive diuretic management will push these animals into acute kidney injury. But for me, the association between inflammation, sepsis, decreased tissue perfusion, those are the patients at risk. Obviously, patients on ventilator, these animals have high pressures. They sometimes keep on a high PEEP. For me, the PEEP is the button not really determining the pressure. It's the GFR button. When you are increasing the PEEP, you are decreasing venous return, you are decreasing preload, you are decreasing afterload, you are decreasing renal perfusion. You can actually watch these patients have normal urine, and then it's becoming more and more and more yellow, and creatinine is starting to increase, and then they have acute kidney injury. There are multiple other reasons for that as well, but those are the patients that, in my mind, are at risk.
Thank you. I think we have one question here.
Thanks, Dr. Segev, for your nice lecture. I have heard you this presentation in the Renal
Week.
Renal Week, yes, and other lectures. I have to ask you about the nutrition in patients with AKI, because although I understand all that you have explained about the fat, etc., I have problems with these patients, because if we administer a high protein diet, it's very difficult to control azotemia, even in dogs with...
it's very difficult to
control azotemia, even in dogs under hemodialysis. So I don't know if it would be better to find a balance between protein and fat.
Yeah, so the comment was regarding the use of diets which are not protein restricted and the control of azotemia. So when we say, and you say that sometimes it's really difficult to control azotemia in dialysis as well, so I'm not sure I completely understand that, because when you do put these patients on dialysis, you can lower their azotemia really nicely. I mean, in our small patients, we are providing a very aggressive dialysis compared to human medicine. So if human medicine would be a KT over V of 1.3, we oftentimes would provide double than that and even more than that. So I don't personally find any problem in controlling azotemia in those patients who are managed with hemodialysis, especially if we are doing IHD. In CRRT, it may be a little bit more challenge if you have a very big patient, but still our patients are so much smaller compared to human patients, so if they can do it, probably we can. And the reason for that, for the not restricting protein, is coming from the evidence that we have that these animals really lose a lot of nitrogen. But we don't have good evidence for that. There are some nutritionists in the back. Maybe you have additional thoughts or comments about protein restriction in those animals. We used to study a lot about these patients on hemodialysis to formulate diets for them. So I agree that we don't have a lot of evidence, but I would not think that nitrogen supplementation and protein supplementation and the association with azotemia would prevent me from feeding this type of diet. And I'm more concerned in dogs about high-fat diets, because these high-fat diets, if they are going to cause pancreatitis, this is going back to the question that Sarah had asked, inflammation again, inflammatory process, that may worsen kidney injuries. So that is kind of my thoughts about that.
Good. We have another question from the chat while we're getting the microphone over there. So in AKI with hypertension, so even if we've normalized the hydration status, can we use ACE inhibitors or ARBs to treat the hypertension?
We do not recommend that. So first we have to remember that especially in ACE inhibitors and also ARBs, unless you're going to high dosages, they are not very, very potent antihypertensive medications. So ACE inhibitors may drop the blood pressure in 10 to 20 millimeters of mercury. Many times these animals need more aggressive management than that. The concern is that these medications have the potential to drop GFR further. And so we think that we can control these animals using the drugs that I had mentioned, mostly amlodipine and if needed hydralazine as well, without the risk of dropping GFR further. So this is why we do not recommend the use of ACE inhibitors or ARBs.
Good, thank you. We have two questions right over here.
Thank you very much for your talk. You talked about hospital-acquired AKI. How much of that AKI that we see do you think in your personal experience is caused by iatrogenic fluid overload rather than primary disease?
So the question was about hospital-acquired AKI and the association with fluid overload. I don't know that they know the answer for that, I believe. I think that in most patients without acute kidney injury, they don't have severe overload. I mean, we do manage these patients with a lot of fluids, and if we look at that very critically, probably many of the patients that are being hospitalized and receive IV fluids are a little bit overhydrated, because this is what we tend to do. But this is not becoming severe as long as your kidney is working. When you have acute kidney injury and you have decreased urine production, these patients then become severely overhydrated. And now in those patients, if you ask the question, how much of this overhydration now, after AKI was already established, is that further contributing to AKI? The answer is absolutely yes. We know that there is a congestive nephropathy. We know that this edema in multiple organs may be detrimental for these patients. We sometimes have these patients presenting to us with severe overhydration, severe azotemia. We would start hemodialysis, start ultrafiltration, and once you remove fluids, you start seeing increased urine production. And this is suggesting that this fluid overload is important in congestive nephropathy, but as an etiology for AKI initiation, I don't think that's a major issue.
Hi, thank you for your very useful talk. I just had a question regarding your data on the recovery of AKI. I assume that this is about animals who received hemodialysis.
No, not necessarily. Most of these animals actually did not. Of the 250 animals that we have, most of them did not receive dialysis.
Okay, perfect. So we can apply these figures in animals which do not receive these
Definitely, but those were animals at all AKI grades, and so obviously, as you saw, the mortality rate was much lower in the lower AKI grades, but overall, if you look at all spectrum of AKI, I think that is representing the survival rate. So these are not hemodialysis dependent patients for the most part.
Perfect, thank you.
Excellent. So one last quick question from the chat, Gilad. So any insight on managing babesiosis and ongoing AKI, especially understanding that some of the drugs used to treat babesiosis may potentiate AKI?
Yeah, so I do not think that I have personally a lot of experience with that, the management of babesiosis concurrently with AKI. I don't see these patients a lot, so I don't think I have a very good insight about that. I mean, obviously, if you have clinical babesiosis, you would need to use these medications, but in the setting of AKI, this is not something that I see very commonly. So interesting to see whether where this question is coming from. Is it that South Africa or?
Yeah, we'll try to address it in the chat. Maybe we'll group source it and see for people who are used to managing.
Okay,
babesiosis.
perfect. So moving on to the next one. Okay. So next lecture, I can try and do without my slides, but it's better to have them actually. Okay, moving on. So that is the exciting area of renal biomarkers and what we had learned over the years. So we are starting a little bit late because of all of these questions and discussion, which was very good. So I apologize for that. So when we try to assess kidney function, we know, or kidney integrity, I would say, we can categorize our markers into basically two markers. We have the functional markers that would change only when we have change in kidney function. Those would include creatinine, SDMA, BUN, and also GFR and urine-specific gravity. Those are functional markers. And there are some markers that we had probably ignored over the years, like urinary cast and glucosuria as markers of acute kidney injury. And the reason why we kind of ignore those is due to the lack of very low sensitivity of these markers as markers for acute kidney injury and obviously for chronic kidney disease as well. So the question is, what is the role of these biomarkers or additional or novel biomarkers in the management of acute kidney injury or chronic kidney disease? So my journey, at least with biomarkers, started with acute kidney injury. I wanted to see if these biomarkers can identify the disease. The biomarkers were emerging on the human side. Can we use, as a profession, these biomarkers in the AKI setting? And so these, you can see here two biomarkers, urine cystatin B, which is the one that is going to be available for us, and urine clustering. And we tried to look at patients with acute kidney injury. We also included animals with chronic kidney disease, control group, lower urinary tract infection, and we did demonstrate initially that these biomarkers do increase substantially in the AKI setting. So that's nice, but these were dogs with acute kidney injury grade 2 to 5. So that means that they were azotemic. So do we need additional biomarkers to tell us that there is an acute kidney injury when we already know that we have acute kidney injury? So probably these biomarkers can tell us more about the disease, but not necessarily to diagnose acute kidney injury if you already know that. The next question was, are these biomarkers more sensitive to acute kidney injury? And these are what you see here is dogs that receive gentamicin. You can see here a very long x-axis up to 2 months, and you see a biomarker here, and you see creatinine here, and you can see that when these dogs are receiving gentamicin, you may see an increase in the biomarker concentration already at day 8 or 9, so biomarker is increasing. Now, if we look at creatinine concentration, only 8 days later, creatinine would start to increase, actually start to increase within the reference range. So these biomarkers can indicate presence of acute kidney injury way before we have any change in kidney function. And if we had known that, we can discontinue nephrotoxic administration of some medications to prevent acute kidney injury. So this is an example of how these biomarkers can identify acute kidney injury relatively early in the course of the disease. And what is really interesting is that then when these animals are recovering from AKI, the biomarkers decrease around 2 days before we have any improvement in kidney function. So potentially they may also indicate healing processes. And it makes sense. Injuries should subside before we have increase in the function of the organ. We also looked at markers, those markers as predictors of acute kidney injury before and after anesthesia. So what you see here are 80 dogs which are stratified based on their ASA status, so the risk for anesthesia. So this is one group, second group, third group, and fourth group. So these patients have a higher risk of AKI following anesthesia. And we look at a functional marker like serum creatinine. You see that there's the mild increase in creatinine concentration in ASA status 1. This is interesting because ASA status 1 in our institution basically were student space. So actually these space take a lot of time, and sometimes you may see a mild increase in creatinine concentration. That is an observation that we had made. And you don't see the change in ASA status 2, and actually you see a drop in ASA status 3 and 4. And this drop in creatinine is probably due to a dilutional effect. These animals receive a lot of fluids because they have higher risk of acute kidney injury. Now, if you look at biomarkers, consistent with what we had seen in creatinine, there is a mild increase in ASA status ASA status 1. We don't see a change in 2, but actually in 3 and 4, you see a relatively marked and statistically significant increase in the concentration of these biomarkers. Now think about it. If you go take a dog to surgery in ASA status 3, you measure creatinine before anesthesia, you measure creatinine after anesthesia, you get a drop and you are happy. We didn't have any injury to the kidney, but in fact, this kidney has acute kidney injury. It may be grade 1, but still this is something to pay attention to. So these markers can really help us in the early diagnosis of AKI. So again, we have to identify those patients that we consider to be at risk for AKI and screen these patients to identify the disease early. Again, what do you do with grade 1 AKI? We talked about that in the previous lecture. It is interesting to know that some of these biomarkers were actually associated with the outcome. This is a different study. Look at serum creatinine concentration between two groups, survivors and non-survivors with AKI, no statistically significant difference, and there is a difference between survivors and non-survivors in the concentration of biomarkers. Now, that was not really consistent across the board. That was not very consistent in various studies. Looking at different biomarkers, we still have to evaluate that. So it's probably kind of a surrogate marker for the disease severity, but we know that the prognosis of AKI is influenced by multiple factors and not only the severity, as we had mentioned. So this is how we started the journey looking at biomarkers for AKI, because that was the most interesting thing back then. But then when we look at these kind of designs, and regardless of the biomarker that we were looking at, we also included animals with chronic kidney disease. And those animals, based on the inclusion criteria, were animals with stable chronic kidney disease. They had stable kidney function. Kidney function did not change, so we were happy, nothing's going on in this kidney. But actually, if you look at these biomarkers, they are not increased as you would see in acute kidney injury, but they are markedly increased compared to healthy controls. So what's going on with these kidneys? Something is going on. These are markers of tubular damage, tubular injuries. So you have ongoing damage in those animals, which we think are very stable. And this is really where some of the research, in my interest at least, shifted towards CKD. So CKD, as you all know, is defined as structural or functional changes that are present for more than 3 months. it tends to be irreversible and progressive in nature, but we know it is progressive, but there's a great deal of variability. There are differences between dogs and cats. There are differences within the species. We know that there are some cats that are extremely stable for a long period of time. There are other cats that are more progressive. And so what is the reason for that? So rate of progression really varies among species and within individuals. And what is happening in chronic kidney disease, and this is just a scheme, but I think is kind of representation of the problem that we are dealing with. And so we're looking here at 3 years, and this is just all made up numbers, so don't take these numbers as numbers to remember, but the principle is that we have initially normal kidney function, and we have a certain number of nephrons that are functioning. You can see creatinine, you can see GFR. As we lose nephrons in CKD, and this is something that is happening in CKD, we do not necessarily see a change in function. So GFR is not dropping and creatinine is not increasing, or SDMA is not increasing, because we have concurrently secondary hypertrophy processes going on. So if you guys are reading in the textbook, and probably you had heard that and read that GFR is the most sensitive marker of CKD, well, not necessarily. It's not. It cannot indicate the disease, because these GFR, or the decrease in the number of nephron, is masked by compensatory hypertrophy. And this may just continue, and initially, after these secondary compensatory hypertrophy processes had been exhausted, now any drop in the number of nephrons is going to be associated with some increase in creatinine. You remember the nonlinear relationship between creatinine and GFR, so substantial drops will be associated with only mild increase in creatinine concentration, probably within the reference range. Probably we are not going to pay attention to that, and only at later stages of the disease we would identify these patients, because the disease is also subclinical initially. So if this is the timeline for acute kidney injury, we probably treat here like 5% of the disease, 10% of the disease. Again, these are just made up numbers, but I think it's representing the problem, because we do not have very sensitive markers of the disease. So if we had some sensitive markers, maybe we can identify intrarenal processes in those animals that actually occur already here. And maybe we can identify the disease, and maybe we can do something to prevent progression and delay the onset of clinical signs. One of the things, again, that we have been teaching is that the disease tends to be progressive. And one of the reasons for the progression is those secondary maladaptive processes that occur. They are good for the short term. They are not necessarily good for the long term. So this is kind of a scheme of nephrons. You have the intraglomerular pressure, which is the main force of filtration. And when we start to lose nephrons, there are some adaptations that will cause hyperfiltration. So this hydrostatic pressure within the glomerular capillaries may increase, will increase the single nephron GFR, but that's going to come on the expense of high pressure here. And so if we look at some models and you see what's happening before or after you remove, let's say 95% of kidney mass, you see this hypertrophy only after a few weeks. You can see that the single nephron GFR is increasing substantially. So this is the secondary compensatory processes that mask the decrease in number of nephrons and maintaining GFR initially. So that sounds really good for the short term, but for the long term, that may be a maladaptation that eventually would lead to further progression. So this is one of the reasons why we think that chronic kidney disease is progressive. And we know that that is the case if you remove 95% of kidney mass, and now you have chronic kidney disease, the disease oftentimes progresses. We talked about that study just in the previous lecture, and one of the things that we had found in these studies, so remember 66% of the patients recover, and of those 66%, 75% had normalization of serum creatinine concentration, but 25% did not. So those animals have CKD, and these are dogs, they should progress now. But actually, I already presented that these animals are not progressing. So maybe there are some things that we do not understand. Maybe these dogs do not always follow the same pattern that we expect them to, because you don't see a change in the survival time between animals that did or did not develop chronic kidney disease. So why this is happening in these dogs? Actually, in our study, only 8% of the dogs died due to further progression of chronic kidney disease. So why these animals are not progressing? And so we had speculated on that, and a few speculations were, first, regarding the etiology, the inciting cause. If you have chronic kidney disease, acquired chronic kidney disease, that means that oftentimes that you have some etiologies or etiology that had made these kidneys to progress from a normal functional kidney to a kidney with decreased number of nephrons and decreased GFR. And this etiology, regardless if we understand that or not, is going to exert its negative effect throughout the course of the disease. It's going to push for further progression. So that is one option. But you may argue that that's not a good explanation, because what happens when you have these animal models in which you remove, using a scalpel, not other etiology, you remove 95% of kidney mass. Then these animals do progress despite the fact that they don't have etiology. But we believe that there is a difference between these maladaptive processes when you have 95% of the kidney mass removed and these are fully activated, compared to animals that may have now 20% functioning kidneys. So their creatinine maybe is in the 2 range, or 2.5 or 30% functioning nephrons, and then these secondary compensatory processes are not being activated to their full extent. So in the absence of these compensatory mechanisms and in the absence of etiology, these animals remain very stable. Now, is it true or not? We don't know, but we know that if you remove 50% of kidney mass, for example, kidney donation, for example, you are not likely to progress, right? So 50% doesn't do that. 95% does. Well, what's happening in the middle? Probably if those animals recover enough, these secondary compensatory mechanisms are not being activated. And so this is just to demonstrate that up to now, we look at chronic kidney disease as one entity, but in fact, it may have multiple variation. That is also true in cats. We know that some cats with chronic kidney disease are extremely stable. Maybe this is just loss of nephrons in time in these geriatric animals, whereas other cats progress like dogs progress. So do these cats have the same disease? Maybe these are just two different entities, and we can maybe characterize that better using biomarkers. So this is what we're trying to do. So I think up to now as a profession, both in veterinary and human medicine, we're looking at the output of the kidney. This is creatinine. This is urine-specific gravity. This is SDMA. This is only the output without understanding the intrarenal processes using these biomarkers very, very thoroughly. So we are looking at the tip of the iceberg only. What we're trying to do now is to characterize the intrarenal processes that may occur in chronic kidney disease. So you may look at different biomarkers that would inform us about tubular damage, and we already talked about some of these markers that are associated with tubular damage, some markers that may be associated with inflammation, oxidative stress, and fibrosis. So do these markers exist in animals with chronic kidney disease? So let's start and look at markers of tubular damage. We're looking at animals that are defined as stable chronic kidney disease. Creatinine, SDMA does not change. We are happy. We think that nothing really is going on, but if you look at tubular damage across the board in different stages of the disease using different markers, and again we have here clustering and cystatin B, you can see that active tubular damage is already present at stage 1 disease. In those animals at stage 1, they already have biomarker concentration which are high, and the reason why you don't see a reference range is because it's really here on the x-axis, basically parallel to the x-axis. So all of these patients, all of these grades, sorry, have active tubular damage. When we think that nothing's going on, the animal is stable. So as from stage 1, the degree of damage is comparable to what we see in other stages of the disease. What about markers of oxidative stress and damage? We know that there is a balance between the generation of reactive oxygen species and different mechanisms present in different levels to negate the effect of these reactive oxygen species. We also know that the kidney is very actively metabolically, so there is constant generation of reactive oxygen species and a high degree of oxidative stress in those animals. If we look at the human literature, and this is just for illustration, not for you to read, we know that oxidative stress and damage had been documented in multiple studies looking at the association between the degree of oxidative stress and the disease progression rate and inflammation, proteinuria, fibrosis, and others. So this association exists. Does that exist in our veterinary patients? So the problem is it's really difficult to measure these reactive oxygen species. They have very short half-life, difficult to measure, but you can use some markers for oxidative stress like isoprostanes. And these are family of prostaglandin-like compounds which are produced by non-enzymatic peroxidation of arachidonic acid. So this arachidonic acid can be attacked at different locations by these reactive oxygen species to generate isoprostanes or different types of isoprostanes. So do we have any evidence for oxidative stress in our patients with chronic kidney disease? The answer is yes. And initially when we looked at these results, that was a little bit surprising because in our mind, we think that things are going to get worse over time. So moving from stage 1 to stage 4, we expect things to be actually much worse, but that's not the case because this is a kidney with chronic kidney disease. This is the scar tissue, right? In stage 4, most of the kidney is a scar tissue, so this kidney is not really active metabolically, so actually it makes sense that this oxidative stress is present very early in the course of the disease. Again, this is probably our target, stage 1. We see that many of these processes occur in stage 1 disease, active tubular damage, oxidative stress. If we can only identify the disease early and intervene early, maybe we can prevent progression. And this is very consistent with the study by the group of Jessica Quimby looking at oxidative stress in cats. And you can see basically the same results. So this is really interesting. What about inflammation? Do we have intrarenal inflammation in these patients? We know that lymphocytes are present there. What exactly do they do? And we know that from data coming from the human side, that these intrarenal lymphocytes have very important role in mediating inflammation. And so we have some injury. It can be tubular injury, vascular injury, and there is a cascade that is mediated by these intrarenal lymphocytes. And so when we look at different inflammatory markers in the urine, like you see here, IL-6, 18, 2, 18, A, TNF, they are all elevated. Again, we don't have a good reference range for these biomarkers. When we look at some of these markers in healthy animals, basically you get no response. And so intrarenal inflammation, it's probably another thing that is going on in these patients. What about markers of fibrosis? We know that there is a very close association between intrarenal inflammation and fibrosis. And fibrosis is the healing process. That is a good thing. However, if you have chronic inflammation and chronic activation of fibroblasts, that will end up in fibrosis, and extensive fibrosis. So this is a very common pathological outcome of many chronic inflammatory processes. And we know that this is one of the hallmarks of chronic kidney disease. So if we have chronic inflammation, we have pathological fibrosis. And if we take biopsies from these patients and assess for fibrosis, we can identify that fibrosis is actually present. Can we look at markers of fibrosis? So TGF-beta seems to be one of the promising biomarkers and a common fibrotic pathway marker that we can look at. It has both anti-inflammatory and pro-fibrotic activity. It can be used as a target as well, and inhibition of TGF-beta signaling pathway reduce development of fibrosis in multiple models, so that may be a target. Do we see fibrosis? Obviously, we see fibrosis. Do we see TGF-beta as the marker of fibrosis during CKD? The answer is yes. If we look at different stages of the disease, you can see elevated TGF-beta. Now again, very interesting and recognizing that these are at this point relatively small numbers, but TGF-beta is already elevated at stage 1 disease. So again, this is our time to identify and intervene, and maybe we can prevent some of these inevitable processes that occur. And so probably if we use an array of biomarkers, we can characterize the disease better. Maybe we can have few biomarkers that will tell us about different processes that are present in different etiologies and different, and they may be not predominant in one stage compared to the other, or in one etiology compared to the other. So this is an opportunity when we have these biomarkers to really characterize the disease and maybe to differentiate those animals that we just put them in one box and call them chronic kidney disease and expect them to do the very same thing. They are different. They have different processes. And maybe this is just few of the processes. Potentially there are multiple other processes and they have multiple interactions. So it's really only the early phases of understanding all the interactions that may be present out there. Now the question is, do we really care? I mean, what do we care about all of these biomarkers? Are they associated with a progression rate of CKD? And we have evidence for that as well. So this evidence is coming from a multi-center study, including a few centers, UC Davis, Minnesota, NC State, Hebrew University, in collaboration with IDEX. And we looked at animals with chronic kidney disease and followed these animals over time. And we had these animals coming to the clinic once a month, and we looked at various parameters. So this study included around 220 dogs with CKD that were followed, and I will present some data that we had on urinary cystatin and clustering. Now there are a few options how you would look at that and how you analyze whether these markers that we are measuring are associated with progression or not. And so this is one of the ways. I will show you another way. So the problem during the follow-up period is that these markers may just go up and down over time. So this is just representing one dog. So in that analysis, what I've done is calculated the area under the curve just to see how much exposure, if you will, had this individual dog had to tubular injury, tubular damage. Did the activity of these markers were very high in this specific individual comparing to other dogs? And we categorize these dogs as to rapidly progressive versus slowly progressive disease. And we looked whether there is a difference in the activity of these biomarkers. And you can see here for both clustering and cystatin B that those dogs that were classified as rapidly progressive disease actually had higher tubular damage. And this is for both biomarkers. There is an overlap, obviously, but actually it seems to be higher overlap than there is because of this very high y-axis. This is highly statistically significant. So those animals, and it makes sense, that have high tubular damage, high degree of tubular damage, it makes sense that these animals would progress faster, and you have an evidence for that. We also specifically looked at CKD stage 1, and I already emphasized that we probably should be looking at CKD stage 1 and intervening earlier. And what you can see here is just a group of patients with CKD stage 1 compared to a control group, and again, slowly progressive compared to rapidly progressive disease. And the progression rate was classified based on the increase in SDMA concentration. We used the 1 inverse SDMA as to categorize these patients to rapidly progressive versus slowly progressive. And what you can see here, that already at presentation, not taking all the data that we had from follow-up, only at presentation, you can also identify those patients that are more likely to progress, because those patients had higher urinary cystatin B already at presentation at the first sample. So these patients have higher degree of active tubular damage. They are more likely to progress. If you analyze the data over time, then you see the same thing. These are highly progressive animals, these are slowly progressive animals, and these are controls. And so you see the difference. And so again, it's just looking at the results in different angles, but we're coming to the same conclusion. The degree of active tubular damage is associated with the disease progression. Now, once these biomarkers are going to be available to us, we need to understand how we should use them, and we are still learning about that. So we know that based on the available evidence, active damage is present in those animals, and the degree of damage is associated with a progression rate. So how should we use them? Are we going to look at a reference range, or are we going to compare these biomarkers from one visit to the other? And to know that, we have to understand how these biomarkers behave. So if we really look generally, we know that each biomarker may have some variability, biological variability, which is associated with or composed of the intra-individual variability, how much this biomarker is changing within an individual from one day to the other. The inter-individual variability, what is the difference in the biomarker concentration between a group of patients, and the analytical variability. And we can also use another term, which is the index of individuality, which is the relationship between the intra and the inter-individual variability. How much this biomarker is changing in individual compared to the population. And there are some markers that are really, really stable within the individual, or relatively stable, but they are really different from one patient to the other. I don't know if you know some of these biomarkers. Maybe creatinine would be one, right? Very consistent within the individual, but a huge difference between dog breeds, for example, right? One breed may have a baseline creatinine concentration of 0.6 and the other would have 1.4. So these markers are not very suitable for reference range. You should look at individual patient. This is something that we are advocating for many, many years. Don't look at the general reference range for creatinine because it's so wide. Look at trends over time. Compare the individual creatinine to subsequent measurement. And there are some markers that behave differently. They have high index of individuality. They may vary within the individual, but they are quite consistent amount within the population. So these are more suitable for reference range. We looked at how much these biomarkers change from one day to the other. For some biomarkers, I think we have to do it for other biomarkers as well. But just to get an impression how much these biomarkers change over time, we took animals with stable chronic kidney disease over a short period of time, during which we closed these animals very closely to make sure that they are stable. Nothing is really happening. And we took urine 4 times during this period of time and looked at 2 biomarkers in that scenario, NGAL and Q1, to show what is the variability, how much these biomarkers change over time. And we calculated the coefficient of variance for these biomarkers. And actually, it seems like a high number, 40% and 30%, but that is not too much. It's not too much because when these biomarkers, or these animals may have acute insult, these biomarkers would go by hundreds percent or thousands, so many folds increase in the biomarker. So if they're changing only 40% and maybe up to 100% if you want to include the entire range, then if you know what the baseline biomarker is and you have follow-up measurement, you know when something is happening. We asked the question, what's happening to the coefficient of variance if you normalize that to creatinine, because you know that many biomarkers are being normalized to creatinine, and actually not a lot, because these animals had already lost urine concentration ability. So it's not very important to normalize to creatinine when you look at the variability. But I think that is an exercise that we will have to do for each one of these biomarkers in the future that is going to be available to know how to interpret a change in the biomarker. I think these biomarkers really gives us the opportunity to look for different intervention. It's really difficult to look for intervention for chronic kidney disease, because if you're looking at and evaluating these intervention using functional markers, these markers are so slow to change, and so many things are happening along the way, and it's really difficult to control all of these things unless you have thousands of cases, and you can do that. But the real-time markers gives us the opportunity to test an intervention and to see immediately if we have a response or not, and only then take these to a more comprehensive evaluation. So just to summarize what we had seen today, animals with chronic kidney disease have active ongoing damage, and biomarkers may help us maybe early in the diagnosis of stage 1 disease. They can help us to understand intrarenal processes in CKD. They can be a surrogate marker for the progression rate, and they are real-time indicators of therapeutic intervention. So with that, I'm going to conclude. I have to thank Gilad, which is the one who is doing all this work. We're doing that together. That's not my data, that's our data. And so thank her, and thank you for listening today. Do we have time for questions, or?
Yeah, so let's do one quick question, and then for the rest of you who have questions, maybe come up and chat with Gilad after. A wonderful overview, by the way. So any questions from the audience?
They're hungry.
Excellent. If you do have questions, feel free to come up, Gilad, if you wouldn't mind sticking around just for 1 minute. Wonderful overview of emerging biomarkers. So thank you all for sticking with us, and enjoy your lunch.
Okay, so sorry, don't stand up, because now we will be the next talk.
Oh, my apologies. We eat a little bit later here in Barcelona than we do in the US.
I guess everyone is hungry, so don't worry, there is not so long, it's only half an hour more, and then we will break for lunch. But now we will introduce Dottie Laflamme. That will be the next speaker. Please go ahead.
Hello, I'll be speaking in a minute. I'm Drew Wagner, one of the former presidents of EveryCat Health Foundation. You've seen our sign up here, and we'll talk about that in just a minute. But it's my pleasure to introduce Dottie Laflamme. Before I do so, there's some very quick housekeeping items which most of you've heard before. Make sure your phones are switched to silent. You know where the toilets are. Lunch will be served on the terrace on the ground floor at 1 o'clock. That's the important one. And questions for the speakers can be submitted by the virtual attendees via the chat function. So Dr. Laflamme received her master's degree in ruminant nutrition, a doctor of veterinary medicine degree, and a PhD in nutrition and physiology, all from the University of Georgia. She completed her clinical nutrition residency as the Alpo postdoctoral fellow in clinical nutrition. Dr. Laflamme is a diplomate of and past president of the American College of Veterinary Nutrition. She is an author of over 250 scientific and technical publications and has been a speaker at numerous veterinary research and continuing education programs worldwide. She worked for Purina in the Research and Development Department from 1990 until her retirement in 2015. And if her retirement is anything like mine, it hasn't really happened yet. And her research focuses on therapeutic nutrition, especially obesity management and geriatric nutrition. And Dottie lives in the Blue Ridge Mountains of West Virginia, just north of me. Please welcome Dr. Laflamme.
Thank you, Drew. And I'd like to thank EveryCat for inviting me to give this talk on their behalf, and to our sponsors, IDEX and Purina, and to you for being here today. Let's see. So I'm going to talk about phosphorus, generally speaking, dietary phosphorus, with an emphasis on what we know and what we know that we don't know. Of course, I can't talk about what we don't know that we don't know. And we're going to focus on first phosphorus in chronic kidney disease, and then we're going to talk about phosphorus in healthy animals and is that damaging kidneys. And then right at the end, I'm going to invite Drew to come up and talk a little bit about EveryCat's opportunity that they have for funding additional research to fill in some of the gaps on what we don't know. So I'd like to start by briefly going over the IRIS guidelines for dietary management of chronic kidney disease. If you look carefully at the recommendations that they have put out for cats, they do mention chronic renal diets, commercial diets for chronic kidney disease cats beginning in stage 2. Now, they don't specify the specific nutrient makeup of these commercial diets. They just say renal diets. And as you all probably know, not all renal diets are exactly the same. And the renal diets on the market today probably are a little different than what were on the market 20 years ago or 40 years ago and so forth. So that said, I just want to pull out a few things for you to think about in the back of your mind. Now, we're talking about phosphorus in this talk. However, renal diets differ from maintenance diets in a lot more than just phosphorus. Interesting, when most people think about dietary management of chronic kidney disease, one of the first nutrients that comes to mind is protein. If you actually look at the IRIS guidelines, there's no mention of protein whatsoever. Doesn't say anything, period. And the whole question of should we restrict or should we not restrict is a topic for another time, maybe over drinks tonight or something like that. Unfortunately, we don't have time to cover that today, but just be aware that it is a controversial aspect. Sodium, another thing people think, low sodium diet's appropriate for kidney disease. Again, the IRIS group doesn't mention sodium restriction, with the exception that under the subcategory of hypertension, they point out that there's no evidence for benefit of sodium restriction. They do mention the potential of needing potassium and alkalinizing buffers in the later stages, but the main emphasis is on phosphorus restriction. And again, they actually, well, not again, but they talk about serum phosphorus, not dietary phosphorus. So they recommend renal diets, which tend to be phosphorus restricted, but they don't give a specific guideline on what dietary phosphorus should be. They give a guideline on what serum phosphorus should be, using restriction in the diet and or phosphorus binders as needed to maintain a low normal serum phosphorus, and that specific target differs as the condition advances, so they give a little bit more flexibility and so forth. So given that, I just wanted to point out that there remains to be, there's a lot about the dietary management outside of phosphorus that is somewhat controversial. We don't have time to talk about that here, but over the years, we're going to see more and more about that. But let's get on to the phosphorus aspects. A lot of what I'm going to tell you, you already know. People in this room probably know a lot more about kidneys than I do. But that said, I hope that I give you something to think about that maybe is a different way of approaching it, or I didn't realize that. So hopefully everybody will get some of that as we go. But let me review what we do know. We certainly know that elevated serum phosphorus is very common in advanced chronic kidney disease. But as we just heard, we don't really see it elevated early on, even though there is damage going on. We do know that, at least in humans and other species, even within the normal range, a higher serum phosphate is associated with increased risk for renal damage, which probably contributes to the IRIS guidelines of keep it in the low normal. We also know, again, from other species, that phosphorus metabolism appears to be disrupted early in chronic kidney disease, even though serum phosphorus levels stay within the normal range due to phosphorus homeostasis. Because of homeostasis, we know that serum phosphate is poorly correlated with dietary phosphorus. And so whether you increase the intake of dietary phosphorus or decrease the intake, you may not see that reflected chronically, at least, on the serum levels. So it's important that we talk about the homeostasis. Again, I think you all know what's involved with phosphorus homeostasis, and recognize that even though serum phosphorus levels remain normal, there are disruptions or changes, if you will, within the homeostatic mechanisms that play into keeping the serum phosphorus normal. So the primary players here are parathyroid hormone, of course, which helps to get rid of the phosphorus, fibroblast growth factor, active vitamin D, as well as the FGF cofactor, renal alpha klothos. A lot of organs are involved with phosphorus homeostasis. The intestines, which can be up or down regulated in terms of absorption. The bones, which retain calcium and phosphorus, but then release it when prompted. And of course, the kidneys are the primary area for excretion of excess phosphorus. And even though serum phosphorus remains normal, even early in chronic kidney disease, we see or can now see elevations in FGF23. So this is something that historically we haven't been able to monitor, but now that we have markers available, we will be able to monitor that and control for that as appropriate. Now, what happens when phosphorus is increased in chronic kidney disease? In other species, obviously there's a lot going on here. So the excess phosphorus contributes either directly or indirectly to vascular calcification, dysregulated cell signaling, oxidative stress. The release of FGF23 and PTH contribute also to damage to other organs, but also contribute to renal anemia and immune dysfunction, ultimately then contributing to chronic kidney disease. So at least in other species, we know that this damage is occurring directly from phosphates and the potential things like FGF23 and PTH contributing to damage. What about in cats? Obviously, we don't have near the data in cats, but there are some studies that show certainly that serum phosphate levels are associated with damage. So elevations, chronic elevations in serum phosphorus is associated with progression of chronic kidney disease and increased risk for mortality. What about dietary aspects? There's actually, in this grand world of so much data, there's actually one study that's been done in cats that looked at controlling the phosphorus levels and seeing what the benefit was to restricting dietary phosphorus. One level, and it looked at 0.42% phosphorus compared to 1.56%. And this was a renal ablation, so surgically induced chronic renal failure carried over 1 year period. And the groups were fed one of the two different diets for the year. Over the course of the year, there was no difference in GFR, serum urea nitrogen, or serum creatinine. suggesting very slow or no progress in the disease. The low phosphorus diet was associated with PTH, so a decrease there. There was a tendency toward increased survival on the low phosphorus diet, but between the duration of the study and the small size, that could not be confirmed. But pathologically, there were differences between the two groups, with the cats fed the high phosphorus diet having much more extensive histologic damage. So this suggests that cats, like other species, respond in a beneficial way to phosphate restriction. Other studies have been done that looked at phosphate binders, and multiple studies used commercial renal diets being fed to cats, either alone or with phosphate binders, and confirmed that these studies were beneficial. Now that's comparing a phosphate-restricted diet to a maintenance diet, which means that they didn't just differ in phosphorus, they differed also in protein and sodium and ingredients and digestibility and so many other factors. But it does suggest that cats, similar to other species, respond to phosphate restriction. And it contributes to the IRIS guideline in terms of keeping phosphorus in the low normal range. Now, this data doesn't tell us what dietary phosphorus should be. It just tells us that we want to keep the serum phosphate in the low normal range. A relatively new addition to the IRIS guidelines is not only keep serum phosphate low, but keep an eye on calcium as well, because we now know that there is an association, or said another way, there's a feeding phosphorus-restricted renal diets is a risk factor for the development of hypercalcemia in cats that have chronic kidney disease. And because of this risk factor, it tells us that restricting phosphorus is not without adverse effects. So we certainly don't want too much, but what is too little? There is a study that identified that feeding a phosphorus-restricted diet at 0.8 grams of phosphorus per megacal did increase the risk for hypercalcemia, and that feeding a less restricted phosphorus diet was associated with lower risk for hypercalcemia, or even reversed the hypercalcemia that developed in cats that were initially normal calcemic and then developed hypercalcemia on a phosphate-restricted diet, but not when they were already hypercalcemic and then put onto a renal diet with low phosphorus. So bottom line is that if you put a cat on a phosphorus-restricted renal diet and it develops hypercalcemia or hyperionized calcemia, then switching to a less phosphorus-restricted diet may be beneficial and is recommended to try, but you can't always count on the benefit being in all cats. But given that, so the IRIS guidelines relative specifically to hypercalcemia is to recognize that this is a risk when cats are put on phosphate restriction. What they are recommending, and it's now possible to do, is measuring FGF23 to help identify which cats may be more or less at risk for hypercalcemia. And so they're going to suggest that in the absence of hypercalcemia or other indications, that an elevation in FGF23 would be a good indication to start a phosphate-restricted diet. But it's important to monitor serum calcium. And again, if the calcium starts to go up, switch to a less phosphate-restricted diet. One last thing I want to touch on before I leave the chronic kidney disease aspects is the role of acid-base. Now, acidemia was mentioned very briefly in a talk earlier. And I want to point out just a couple of quick things while we're talking about calcium. Acidemia across species It activates parathyroid hormone. It's associated with an increase in ionized serum calcium. It's associated with increase in phosphate excretion. And in chronic kidney disease, it has adverse effects in terms of nitrogen balance, so that the acidosis actually decreases nitrogen balance, it decreases protein synthesis and increases protein catabolism, and of course it's associated with an increased progression of chronic kidney disease. In humans and in rodents, treating with simply addition of bicarbonate has actually been able to reverse some of these adverse effects associated with the acidosis of chronic kidney disease. There's certainly no evidence of that in cats because it really hasn't been looked at. Metabolic acidosis is well recognized to occur in cats, but only in later stages of chronic kidney disease. But in humans, even within a normal pH, the slightly more acid effects can be seen in terms of nitrogen balance and others. Whether or not this happens in cats remains to be seen. But since we're talking about hypercalcemia, I just threw this up here to point out that this is one of the contributors to hypercalcemia, and perhaps it occurs in cats as well. So let's switch to healthy cats. And does dietary phosphorus harm the kidneys of healthy cats? In rodents and in humans, there's now evidence that high phosphorus diets can actually cause damage to the kidneys of otherwise, healthy rats. This is associated with the use of highly soluble phosphorus salts, inverse calcium phosphorus ratio, inadequate dietary magnesium, and other aspects that influence phosphorus availability. Phosphorus source is a big factor. And so this has been data accumulating over actually quite a few years. And so our question here this morning is, what about in cats? Are cats also affected so that these excess dietary phosphorus aspects can have damage to cats' kidneys? Well, before we talk about that, I think it's important to address the nomenclature of what do we mean when we're talking about phosphorus, and are we talking about organic or inorganic phosphorus sources, which are terms that are currently now being used in the veterinary literature. But I have a problem with that because essentially phosphorus is a mineral, and by definition a mineral is inorganic. But what the people using these terms generally mean is the source coming from an organic substance such as meat or bone, or is it coming from an inorganic substance such as mind? I actually prefer a different categorization of your phosphorus sources and thinking about it. Is it there for a nutritional purpose because phosphorus is an essential nutrient, or is it there for a functional benefit? And so when we're talking about nutritional sources, generally those ingredients used, if you will, are going to be animal tissues like meat and bone meal, but there's also phosphorus available in grains, and there's also mined phosphates such as calcium phosphate or dicalcium phosphate, tricalcium phosphate, which are different from a physiologic point of view from what we might consider functional sources, which are those that are provided either to influence the foodstuff, such as a preservative, or perhaps for a structural or even a palatability benefit, or an acidification, such as the use of phosphoric acid to acidify urine and the control of struvite. And then there's the phosphate salts, which again are used for a specific purpose in the food, but get to the point of contention regarding dietary phosphates. There's a difference in the bioavailability of different phosphate sources. So this is data from swine and poultry, which shows that the sodium phosphates are the most bioavailable. These are very highly digestible, readily absorbed phosphate sources. And all other phosphorus sources, including the organic versions of meat and bone meal or fish meal or meat, or the mined calcium phosphate and so forth, or the sources in vegetable matter, are less available to the animal. But again, that was data in pigs, and cats are not little dogs and they're not little pigs. So how does this apply to cats? Well, there's certainly evidence that in this regard, cats are similar, and that the intestinal uptake of the highly available sodium phosphates can be twice that compared to the phosphorus in animal source phosphorus. And that's been known for quite some time. So starting in 95, but most of the studies I'm going to briefly go over for you have been much newer, but looking at this, the question is there an impact on the kidneys when these highly bioavailable phosphate sources are provided to cats? So this first study by Pasteur looked at 4 different diets with 0.6 up to 3.6 grams of phosphate per megacal, with calcium phosphorus ratios going down. As phosphorus went up, they held calcium constant, and the calcium phosphorus ratio changed from 1.8 all the way down to 0.3. And calcium phosphorus ratios are critically important because these two minerals offset one another, kind of counterbalance one another. Higher calcium will reduce the amount of phosphorus absorption, as well as the amount that's bioavailable within the bloodstream and so forth. So the calcium phosphorus ratio is important. So in the Pasteur study, what they showed is that in these 1-month studies, that feeding the highest level of phosphorus with the lowest level of calcium phosphorus ratio, there were acute changes in creatinine clearance, and so renal damage within a very short period of time with this particular study. And mind you, this is using the sodium phosphate. That's important to keep in mind. Newer studies out of Germany with several different diets, again with an inverse calcium phosphorus ratio, about 1.3 to about 3.7 grams per megacal of highly soluble phosphorus. They were able to document, again, injury to the kidneys in terms of microalbuminuria, glucoseuria, reduced creatinine clearance. Another study out of that same group, similar diets, but in this case holding the calcium phosphorus ratio constant at about 1.3. They did not have as severe of changes, but did see greater phosphaturia and glucoseuria with the sodium phosphate, but not with calcium phosphate. Other studies looked at, again, the calcium phosphate diets, the sodium phosphate diets, with calcium phosphorus ratio varying between 0.9 up to 1.3. And here we, again, with these highly soluble fibers, see some changes in the kidneys. Then with calcium phosphate and a ratio of 0.4 to 1, there was kidney damage induced, but when calcium phosphorus was raised up to 1.3 to 1, there was no apparent damage to the kidneys. Finally, studies out of Alexander, similar amounts that when phosphate was at 4.8 grams per megacal from sodium phosphates, there was an adverse effect on kidney function. When they stopped that study after about 6 weeks, and then later did another study, but they only went to 3.6 grams of phosphate, and didn't go quite as low on their calcium phosphorus ratio. And they saw, this time, no change in GFR, but there were still some changes in the kidney. So even at that level, there was some evidence of injury to the kidneys. So basically, all these different studies together show us a pretty clear picture that high amounts of inorganic phosphates, specifically the sodium phosphates, which are highly bioavailable, they do cause damage to the kidneys, even in otherwise normal, healthy cats. But it's been shown that similar amounts of phosphorus, or if the calcium-phosphorus ratio is higher, then these adverse effects don't occur. So the source and the amount of phosphorus, the calcium-phosphorus ratio, and other factors, which also can include dietary magnesium, dietary fiber, things that influence the absorption of phosphorus, can have an effect on that. And as I just mentioned, if the phosphorus, even at high levels, if that phosphorus is coming from less bioavailable sources, then you don't get the same adverse effects. So it's not the amount of phosphorus per se, it seems to be very much related to the highly available phosphorus sources. And to date, there's no evidence that commercial diets, regardless of the phosphorus in them, cause harm. But I emphasize that's no evidence to date that causes harm, because I want to show you a quick look at the phosphorus content, average phosphorus content in different diets. If we look at the diets and the studies I just shared with you briefly, those diets that had adverse effects on the kidneys, the phosphorus was between about 3.6 and 4.8 grams per megacal, with a calcium phosphorus ratio of all the way down to 0.3 up to about 0.9. Amongst the research diets that were either the control diet or had no noticeable adverse effects on the kidneys, the phosphorus levels were 1.2 to 3.2, and calcium phosphorus ratio basically between 1 and 1.8. But if we look at average or typical commercial diets, we have data on the US and in this case also Brazil. You can see that the overlap between the range of diets available on the market and the diets that were associated with adverse effects in the studies, that there is an overlap. So we see, for example, phosphorus as high as 4.9, 5.8, and calcium phosphorus ratios of 0.5 and 0.8. So one has to be suspicious that there may be diets on the market that could put cats at risk, but then it comes down to what is the source of that phosphorus, and if that source is coming from, for example, animal tissue, it's less of a risk than if a diet happened to have a large amount of sodium phosphate in it, which, again, I'm going to mention from a commercial point of view, that is used in some foods, sodium phosphates and so forth, but usually in trace amounts. So it's difficult to know if any of these diets are likely to cause problems for cats. So bottom line is, based on the data that I showed you, we know that phosphorus can cause problems, but there's still more research needed before safe upper limits can be established for cats in terms of dietary phosphorus. What currently is recommended, if you're looking at diets or formulating diets, is to avoid excess inorganic phosphates. Now, what defines excess remains to be debated and researched. There are some who say any of the sodium phosphates is excess, and there's others that say, well, they do provide a benefit in terms of, different aspects of the diet. So there's evidence that there actually have been studied without having any noticeable adverse effects to date. And so maybe there is a safe upper limit that can be established. And the other recommendation is to avoid diets with a calcium phosphorus ratio of less than 1, because almost all of the problematic diets had an inverse calcium phosphorus ratio, whereas more calcium in the diet has been protective. So basically what I was tasked with was identifying for you some of what we know and some of what we don't know so that I can introduce Drew to talk about what our opportunities are. So let me go over what I think I've covered. What we know regarding phosphorus in chronic kidney disease is excess can be harmful. What we don't know is how much is too much, and what we're learning now is how much is too little, because too little might be contributing to hypercalcemia and other issues. What's the impact of phosphorus source in chronic kidney disease? We don't have any evidence of that, but the one study that did look at phosphorus levels actually used a sodium phosphate as the source. So it may not even have been a true phosphorus restriction benefit. It may have been, an issue of the phosphate source. And what are the impact of other nutrients in terms of phosphorus absorption, protein, sodium, and so forth? What we know about phosphorus in healthy kidneys is we know that highly soluble sodium salts of phosphate can be harmful in excess. What we don't know is what the safe level is relative to other nutrients and the composition of the diet, relative to the calcium-phosphorus ratio. We don't know necessarily the maximum safe level of less soluble phosphate salts. Again, there's other nutrients that factor into phosphorus absorption, magnesium, dietary fibers, so forth. We don't necessarily know long-term versus short-term effects. The studies are relatively short-term. But one of the challenges comes back to what our last speaker was talking about, is markers of injury, because even the markers that he was talking about, you can see that there's elevations even in phase 1 kidney disease. But what about markers that can identify an insult to the kidney, but are sensitive enough that you can see differences within healthy cats? Something that's like 0 in healthy cats, and then it goes up to 10 in a cat that's got acute injury, and then it goes back down to 0 after you take away the injury. We don't necessarily have those markers. And so to talk about opportunities to try and address some of these what we don't knows, I'm going to turn the podium back over to Drew to talk about opportunities with every cat.
Thank you, Dottie. So I can't read my own biography, but I'd like to ask for a show of hands. Who has heard of the Every Cat Health Foundation? Well, more than I thought. Who has heard of the Win Feline Foundation? That's us. It's the new name for an old organization. We are indeed the largest source of feline research funds in the world, and we have a long history funding about $10 million to date, but that's logarithmic. Up to 10 years ago, we funded about $5 million. In the last 10 years, we funded another $5 million. And so we'll be a constant source of funds as time goes on. But what we do is fund groundbreaking research that changes the way medicine is practiced. That's what we look for on our proposals. I'm not going to go through this slide or the next one, but you can see we have a very long history of doing this. Echocardiography, taurine deficiency, blood pressure, blood types, high protein, low carbohydrate diets, mirtazapine, on and on and on. And the big one, we had a meeting about this last night about the outbreak of FIP in Cyprus. This treatment of FIP was discovered with funding from Every Cat. So we've been doing this quite a long period of time and have a history of success in doing this. But what we're talking about today is funding a specific study about the role of phosphorus in renal disease. Many of you are internal medicine specialists and very interested in renal disease, but I'm glad to see that there are a number of nutritionists here today as well, because this is a critical issue, and we've just scratched the surface of this. Dottie did a very comprehensive overview of what we know, and it's not really very much yet. So we have funds to study this. But I think one of the biggest factors in this is we also have support to do this. This is the first time both Purina and Mars, the two largest sources of feline diets in the world have collaborated. I have to give them credit for getting together and doing this and putting whatever self-interest they have behind them. This funding is as much for dietary trials as it is for renal diagnostics. We've funded quite a bit in early renal diagnostics. And we've funded a good number of studies to date, but what we found out is when we put out this request for proposals, 2/3 of our studies were coming from international investigators outside the United States. A good number from Europe, some from Australia, and several other countries. And so that's why I'm here today, is to promote this and let you know that this is a source of funds that you can use to study this. There are some stumbling blocks to these investigations that we've identified. It's hard to find investigators with nutritional expertise. So again, I'm very glad to see nutritionists in the audience. The ability to formulate study diets is not the easiest thing in the world. Those of you who have ever tried this before, you know how complicated this is. And I remember learning about this in undergraduate in animal science in formulating diets. And these feeding trials are very labor intensive. But the biggest issue is the potential is there to radically change feline diets and significantly prolong the lives of every cat. That's what we're doing here. You know, I've been practicing medicine for 35 years, feline only medicine for 35 years, but 10 years ago, I left practice to join what was then the Win Feline Foundation's board because I was tired of listening to these lectures saying, well, this is about dogs and we really don't know about cats. Or as Dr. Nielsen said, perhaps, perhaps not. Well, you know what? I got sick and tired of that and decided to do something about it. So the ball is now in your court. You can accept it or you can do something about it, and we're here to help you. Well, I don't know where that slide went, but it just said thank you. There. Thank you all very much.
If I can thank all of our speakers from this morning. In the interest of time, I'm conscious it's the lunch break. If we could maybe just ask Dottie and Gilad, just hang around if anyone has any questions, if they can come to the front and ask them in person. Lunch will be served on the terrace and we'll return for the afternoon session at 2:30. Thank you.
That's just what I needed to hear.
Yeah, yeah. I'm going to get some help to get that
you
off.
and me both.